I'm Dr. Jiang from Beijing, number 307 Hospital, Breast Cancer Department, Academy of Military Medical Science, and focus on breast cancer. And today we have our distinguished guests from the different countries, and we can share the experience and answer the question what the Chinese physician wants to know. Okay, so
thank you. I'm Vernon Harvey. I'm a clinical medical oncologist and I work in Auckland in New Zealand. I also have an associate chair in the Department of Medical Oncology at the university.
Hi, and I'm Sandra Swiney. I'm the medical director of the Washington Cancer Institute at the Washington Hospital Center in Washington, D.C. And I'm also a professor of medicine at Georgetown University.
Hello, I'm Dr. Perez. I'm a deputy director of the Mayo Clinic Cancer Center, and I practice at the Mayo Clinic in Jacksonville, Florida.
Hello, I'm Fabrice André. I'm a medical oncologist and I work in Gustave Roussy Institute in south of Paris, and I work on breast cancer.
Okay, we always heard about the personalized medicine in oncology treatment, but not all the physicians agree. So I think for the MBC, for the early or EBC, maybe it's different. So what's your opinion?
Well, I'll make a comment first, and I think that we've spent 30 years doing these very large adjuvant trials, and we've looked at the Oxford overview where we've looked at all these trials in a meta-analysis and come up with some good answers. But I really think it's time that has changed or is changing, and we're looking at trials now and designing trials that really do look at more of the subset and looking at the biology of the disease. And the kind of trials that have been completed have had thousands of patients. For example, just one that I've done is NSABP B30, where we had over 5,000 patients with node-positive tumors. And we just can't keep doing that. We have too many questions to ask, too many important issues. So not only because of the size of the trials can't we do it, we also are, at this point, only finding very incremental benefits, even though they might be statistically significant. So what we really need to find out are what the targets are, or the personalized medicine, as you suggested, so we can find the very large benefits in the small groups of patients.
Okay,
yeah, to follow up on this issue, it amazes me that we've made so many advances in spite of the lack of in-depth understanding of the biology of breast cancer. But I think it's important for colleagues, physicians, the patients to know that things have been getting better over the last few years, but we're supposed to do a lot better in the years to come. And that's because we have better tools, not only to conduct global clinical trials, but also to utilize tumor specimens to test for different biological markers. So I think it's going to be very, very important that we collect tumor specimens when we design clinical trials so that we can do the translational studies. You know, and until now we've collected mainly specimens that are saved in formalin and then paraffin. And now we understand that in order to do the sophisticated next generation gene sequencing analysis, that we need to start thinking more and more about collecting fresh specimens and then freezing them so that we can do these sophisticated tests. But I think some of the clues that we're starting to get now are very promising, and I feel very enthusiastic about this future of so-called personalized medicine. I know, Fabrice, you're doing a lot of this work in France. I wonder if you can comment a little bit.
I think overall, I agree with the diagnosis that we should go more into personalized medicine. Then the question is how to implement that and how to go forward. And here, I think if we look at what we have now, we have two different progresses in the last few years. First, it was the development of the genomic predictors for prognostic purpose. And from this point, we can go forward because we can identify the patient who do not need additional therapy. So this is a first very important starting point. We can identify the patient who will relapse. And the second point, that was really a big progress, is all what has been done in terms of sample processing, and now we know in the centers how to process samples, how to have frozen sample for clinical use. That was a huge improvement, together with the fact that we have now new technologies to make next generation sequencing, but also gene expression profiling, and now some evaluation of functional activity for kinase and DNA repair. So with this, we can move the next step. One little bit disappointment was the fact that finally, at the present time, if we want to develop some biology-driven trial in the adjuvant setting, we must see that there is not any robust predictor for trastuzumab, for example, or even for several other targeted agents. So we are still missing very robust predictors to move to biology-driven trial in the adjuvant setting. And I think this predictor will come from collaborative work between the main groups from US and Europe.
Okay, thank you. Talking about the clinical trial design and biomarker-driven trial, let's take the example such as PARP1 inhibitors. For the phase 2 trial, it's promising results. But for the triple negative, the phase 3 trial is some kind called disappointed. So what's your comments?
I think the problem there is we don't understand the biology enough. But I wanted to just go back a little bit. I agree with everything that's been said, but I think like all these things, new ways of doing things present new challenges. One of the advantages of those big trials that I agree we're not going to be able to do anymore is that because they don't include any sophisticated testing that you have to do on the patients, then they are available, the results of those are available and applicable for everybody. And I think as we move forward into personalised medicine, we have to work out how we're going to fund the studies that are needed to do the tests that tell us the biology of what we want to explore. Because we struggle enough providing the tools to treat people, the pharmaceutical tools, and yet those are funded, or there are reasonably established ways of taking part of trials and having funding to support those trials. I think it is much more difficult to find the funding to do the preclinical studies in a broader sense. There are many fantastic institutions that do those studies, but the general applicability is not nearly as great, and I think we're going to have real problems of trying to address that.
But I don't think we can afford not to do it.
Well, I agree.
We can't do these $50 or $60 million adjuvant trials, which you get a 2 or 3% benefit, because you're right, it's easy. It's very easy to treat everybody. That we would all sleep better at night. I agonize over how to treat these patients, and am I withholding chemotherapy from somebody that's going to be cured? That's kind of, it's difficult. So it's easy to give everybody the treatment. So my point is we've just got to step back from that. And doing the oncotype and the recurrent score and looking at that has really allowed us to do that even in the node-negative patients. So that's one step. But I think we have a long way to go because not everybody needs chemotherapy. And not everybody needs what we have now. We need to, as you said, discover what's new. But I really think that we have to, as clinical investigators, really highly support that and say this is the way it's got to be done. We can't do these, empiric trials anymore.
I agree absolutely, but I was talking to Fabrice at morning tea, and he tells me, despite the fact that he tells us, yes, we should be doing oncotype, and we should. In France at the moment, it's not reimbursed, so that most of the patients you treat, or the patients you treat off trial, don't actually get oncotype in France, and they certainly don't in New Zealand either, unless the patient happens to be able to afford it.
I think the issue you are raising is the problem of the fact that these new technologies or new gene assays are expensive now and cannot be implemented in different countries. I think for the future is going to change dramatically, and the reason is that all these technologies will become available everywhere, and also now I think the government and the health policy changed their mind, and they want to implement these high throughput technologies in the academic centers. And for example, if we take the illustration in France, we have several trials now that aim at implementing the high throughput technologies in the daily practice, with the idea that in the next 5 or 10 years they will become less expensive, and at the end maybe they will cost less than doing a lot of different multiple assays. So I think you are right, now it's a bit expensive, but we will go in a model where the technology will be less expensive and can be done in different academic centers. So I think it's just a question of finding the appropriate way to implement this test, and this is in the hand of, in France, in the French NCI and government, and they really want to do that. It's really important.
Well, and I think, as you said, you do save money, actually, if you do these tests. And it's not all about money either. You save the toxicity that the patient would have and maybe long-term problems. So there is a big savings there, and I agree. I think it will be done.
Yeah, I think it's always difficult to decide for the early breast cancer treatment for the larger clinical trial, because so many trials. So would you please move to the triple negative, because it's quite hot. Everyone said maybe PARP1 inhibit, maybe cisplatin, but what's really target for the triple negative?
So, this is a true example of the situation we're dealing with. There are a lot of hypotheses, a lot of ideas, and in order to really identify markers that are predictive, we need actually thousands of patients who have been treated in a specific way with appropriate biospecimens, so that we can do the correlative work, and after that then we'll be able to do smaller trials to prove the pilot data or hypotheses that are obtained from these very large studies. And I think it's going to be absolutely critical to do that, because if we have a new drug and we do limited amount of preclinical work, we think, oh, maybe that's the mechanism of action, and then we launch a trial of 300 patients or 500 patients, we may not get the answers. And this is probably evident with the development of the PARP inhibitors, the so-called PARP inhibitors, where for some of them it was not that clear that they were actually acting as PARP inhibitors. And then the phase 2 trial was suggestive of benefit, at least with one of the drugs in Iperib. The phase 3 trial did not corroborate the data, and now we're stepping back to try to better understand the mechanism of action of this one drug. But I think we're in the right path. I think there has been now a realization that the way we were doing things in the past helped some, but we can do a lot better with these new strategies.
And what about like in the neoadjuvant setting? I think that there's so much excitement now, and all the data that we've seen in the last year, especially in the HER2 positive patients, showing the increased pathologic complete response rate. Now we need to correlate that with overall outcome, but maybe that's the path that we should be going and looking for these new targets.
Yeah, I totally agree with you. And then it's a matter of how many patients should we enroll in the neoadjuvant studies to be able to do the appropriate correlative work.
We're actually having a meeting with our FDA to try to decide if pathologic complete response can be used as an endpoint. I mean, there's a lot of data in the world that's been done. The Germans have done a lot. We've done a lot in the NSABP. So it may be that we, will be able to do these smaller studies, but we still have to look for, specifically for triple negative. We don't have the marker yet for that.
Yeah. Talking about the neoadjuvant, I think for the PCR means overall means survival benefit. But for the triple negative or HER2 positive, even some patients get PCR, but doesn't mean prolonged survival.
Right.
So what's your opinion?
Well, I think the answer is going to be on a combination of anatomical improvements and biological markers, and then we'll get the answer.
But most of the studies do show, again, you can say it's retrospective. The NSABP studies, for example, B18 and B27 do show that those patients who have the past CR, even if they're triple negative for B27, that those are the patients that have the survival. So I think that it is, at least in those studies, been a good test of outcome.
But as with all the other groups, it's going to be the same. There are the people who have the PCR are not going to be one group of people, are they? They're going to be various different subgroups within that, just as there will be within the groups that don't get a PCR. And when we identify the differences between those groups, we'll be able to understand, one, where each of those fits, but secondly, where else we need to look to change the outcome better.
Well, I mean, for me, one of the questions you address is whether how can we move from a very large trial to a small trials and get approval with a smaller trial. Personally, I would not use PCR as a endpoint for drug registration, because I think PCR is a very good surrogate for drug bioactivity, that the drug is doing something on the disease. But finally, the problem with PCR, from my point of view, that it does not tell us the medical usefulness of the drug. And maybe you can have a PCR in a patient who was cured by more simple strategies. I take the illustration. If you have in HER2 positive disease, I don't know, 90% of the patient will not have a metastatic relapse. And we have some clinical trial in the neoadjuvant setting that improve by twofold the PCR rate. I want to know what will be at the end the percentage of patients who will be cured by this drug. Is it 1%, 2%, 5%, or is it the 10%? So I need to know the medical usefulness of the drug in the context of the daily practice. And for this, I would not use small neoadjuvant trial. The small neoadjuvant trial, they are good for having a go for phase 3 or larger trial. I think that this is my personal
Okay. We're talking about evidence-based treatment. So let's move to economic-based treatment. It's a source limited for the trastuzumab for the less than 1 year. So what's your opinion? And another question is, how long is we can use for the limited the source country or low income country? Is it different?
Well, we've done a lot of work on this issue, and right now the global recommendation for adjuvant trastuzumab is for 1 year of therapy. That's where the robust data exists. There is a very small, FINHER trial which looked at 9 weeks in fewer than 250 patients. The 95% confidence intervals were quite wide, actually, between 0.2 to about 0.8. So the data are just not robust enough for me to substitute them for the data that have been accumulated in more than 13,000 patients. However, it's also important to realize that there's a lot of interest on this issue. And there are 3 studies that I'm aware of that are currently reevaluating duration of adjuvant trastuzumab. But until those studies are conducted, the best recommendation for our patients is 1 year of therapy.
But the studies are looking at the 9 weeks for the FINHER and then the 6 months. I think in France you're doing the 6 versus 12. So I agree with Edith, but I think philosophically, if you just don't have money, I think the FINHER data for 9 weeks, if it's nothing versus 9 weeks, I would do the 9 weeks. I mean, I think it is a difficult decision, and it really, we all like to be evidence-based, but we all have to live in reality, and if there's no money for it, I think you have to make that kind of decision.
Okay. If the patients have limited resource, you would prefer the 9 week for adjuvant or prefer for neoadjuvant?
Well, I'm very interested in the way Fabrice was looking at that just now, and I think probably in the adjuvant situation myself. I mean, we currently participate in the SOL study, which is comparing 9 weeks with a year, because we think it's an important question.
Yes.
But I agree that a year is the standard. It's interesting when you talk to patients, because when I'm talking about the trial and explaining potential advantages and disadvantages of having the shorter therapy, there are a group of patients who then become very fixated on having the shorter therapy but outside the trial, and that I find is quite a difficult clinical challenge. I feel slightly uncomfortable.
Okay, I think since the time limited, I would say this morning we talk about the art of oncology, but someone will say this guideline should always be followed. But I think for the art, we need to make something new every day, maybe every day. But for the treatment, we should follow the standard, and we can try to run the new standard. But I think before that, we should follow the standard and the guideline and the consensus. So thank you for coming. Thank you for coming to China. Thank you.
Thank you very much.